whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Leaders in Healthcare. I'm Dr. Jordan Vollrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about all things healthcare. Join us as we speak to innovators, industry leaders, and the people working to drive the healthcare system forward. Today we're talking to Dr. Pauwlina Cyca, pharmacist turned physician. She was a former pharmacy operations specialist at Shoppers Drug Mart, president-elect for the New Brunswick College of Pharmacists, Pharmacy Brands Canada. She was one of the founding executives, where she's now the senior advisor for pharmacy services, where they now have a footprint across Canada of more than 200 pharmacy locations. And now, just recently, in the last few years, she is a family medicine resident here in Calgary, where she's the chief resident for the Northwest Division, and also recently was decided as the president-elect for PARA, the Professional Association of Resident Physicians of Alberta, mother of three, and former triathlete. That was a mouthful. Dr. Cyca, thank you for joining us today. How are you doing?
I'm very well. Thank you for having me. I appreciate it very much.
Awesome. Why don't we start a little bit with just the government negotiations and sort of how primary care is going in Alberta. So recently it's been all over the news. The government and the family physicians are a little bit at odds. Everybody's getting tired of the wait times and the lack of doctors in the province. The government decided to put together a task force. The task force decided that the longitudinal family model for family practice was going to be necessary. And then part of what the government took out of that was they decided to put together a second task force to now consult on how that should look. You have been appointed as part of that task force, and that was called what again?
It's the Stabilizing Access to Comprehensive Primary Care in Alberta.
Thank you. How's that going? How are things evolving? I know this is still like early stages. Things are starting to come to a conclusion there. How has it actually gone, from your perspective on the inside, and also just as a new family physician doing your training?
Yeah, certainly it was an interesting process. It's not new to me to serve on these committees. However, this particular task force, it was struck with a level of urgency, as you have already alluded to, and the work was quite voluminous. Is that a good way to describe it? Initially, and it's just started to taper off with some resolution and some decisions from the government. I'd say in terms of how it went, so initially, a huge rush. There were lots of questions, more questions than answers. There were certainly more requests, if you will, from the family physician's standpoint. I served on the task force as a representative for PARA, or the Professional Association of Resident Physicians of Alberta, so that resident physicians could also provide our voice and our opinion. Certainly, the decisions that are impacting family physicians will impact the family resident physicians as well, because a lot of us will be transitioning to practice very shortly. In fact, the R2s will be transitioning in the next 2 months. They're writing their exams now. Any decision that's made now would impact them, which is why we were asked to also have our voices heard on this task force. So super appreciative that we were involved. And initially, things were quite escalated, right? There were a lot of, we need this now, we need this in a week, we need this in 2 weeks. And the objective was to very urgently and acutely stabilize primary care in Alberta so that more family physicians didn't feel the need to leave or didn't feel financial pressure to close their practices. And certainly I didn't appreciate until starting residency how severe the situation was in the community. I had heard of people not being able to access a family doctor, but I didn't understand really the business side of why it was so significantly strained. And it wasn't until after I started in residency and practicing in these clinics that I'm like, oh my gosh, this is dire. Like it's borderline catastrophic. In fact, I would say it is catastrophic. I don't think that is an exaggeration. And so the work that was being done by the task force, which included representatives from AMA, the Alberta Medical Association, from PARA, from Alberta Health, and then there was a third party who also helped facilitate things. lots and lots and lots of collaboration, a lot of big emotions, as you can imagine. And what ended up happening was that proposals were put forward, and each of the different organizations put forward a proposal. And we did our best to come to consensus as to what would be the best and most appropriate proposal to bring to the Minister of Health urgently to have some resolution quickly. And I'm sure that you've heard that there was funding that was committed already, and how that's disseminated equates to $100 million. So 92 million goes to the doctors, 8 million goes to residents. This is the first time that resident physicians will have funding to help stabilize our practice as well. I can get into why that's important in a bit, but it's kind of a big deal. And then that would roll over into the following year with another $100 million being dedicated with the same breakdown. And that funding to family physicians, the intent is to stabilize the practice until the longitudinal family practice funding model, or the LFP, that was initially created, proposed by that first task force, until that comes to fruition, the stabilization funding is supposed to help. So where things got a little bit hairy is who gets the stabilization funding? How do you measure how much each person gets? Because, of course, one of the pillars and one of the mandates of the task force was to increase patient access, which makes sense. So I think that there were a lot of heavy emotions around this because there's a significant number of practitioners whose panel size perhaps don't equate to what the call it subjective or the opinion of certain individuals thought that maybe that should qualify for the stabilization funding. And that's where there were some big emotions. And certainly the Minister of Health, from what we understood, was also receiving information outside of the task force. So when she was doing her rounds in Alberta and meeting people, there were other physicians who were presenting their case to her. And at some point, there must have been some either conflicting information or some very animated discussion around this subject. And that led to some controversy with the work that was being done. So all that to say, it was an eye-opening experience. It was very rewarding. It is very fulfilling. I'm very happy that resident physicians are sitting at the table and providing our voice in the matter. Certainly, resident physicians in Alberta right now are the lowest paid among all physicians in the country. We don't compare ourselves to Quebec because they are paid in kind. So they have funding that is over and above or in addition to and different from a yearly salary. But resident physicians in Alberta, lowest salary. So, and Calgary, as you probably are aware, increased to be one of the highest, if not now the highest cost of living city in the country. So to have the lowest salary and the highest cost of living with no rent control and soaring energy prices and soaring prices for insurance for your car and the whole thing, is becoming almost financially impossible to either pursue or continue a medical degree in this province. So we were just thrilled to have that be included in the stabilization funding.
Yeah, that Alberta advantage that used to be talked about so much is just slowly eroding away through all these different channels. I mean, in terms of the stabilization funding, that's part of the conclusion the government's coming to. I mean, what do you think personally of that outcome? I mean, just back of the napkin calculating $100 million. If there's 10,000 doctors in the province, that's like 10 grand per doctor. Does a 5% one-time bonus to their annual salary, is that going to save primary care? Is that enough? Is that a big part of it? Like, what are your thoughts?
I feel, so I can speak to from the resident perspective, certainly, and I can also offer my opinion from what I've observed in the clinics that I've worked in. Certainly, I have no financial responsibility in those clinics, so it's a little bit different. But my personal opinion is $10,000 per physician will not make a dent. I don't think that is not a sufficient number to maintain the physician in the province. It wouldn't even cover their overhead for a month, right? So I don't think that it's significant enough to save or stabilize primary care. It certainly needs to be more than that. And I think that's also where the conversation was going in the task force, is that would not be significant enough of a number. So then how do we recalculate the monies and make sure that it's going to where it needs to go? And that was part of the controversy, and it's still not completely teased apart, from what I understand. And that makes it complicated. I know that from a resident physician standpoint, that was actually one of the proposals also put forward, 10 grand per resident. And our response to that was, in our unofficial surveys where we solicited the opinions of the family residents in our cohort, nobody would be able to stay for 10 grand, especially when you have other neighboring provinces that are unofficially offering significant sums of money and having no geographical ties whatsoever to the funding. As long as you open a family practice and you hold a panel of a specific size, that's all that matters, right? So we're being poached in essence.
Well, everyone's competing with each other to find doctors. I mean, it's pretty cutthroat out there right now, and I can see how the provinces would be going at each other. In terms of the task force and sort of the suggestions that are put forward, is there anything else that you've seen actually come through on the government side from the recommendations? How are you allowed to talk about this stuff, or is it still under NDA and in discussions with the government? This podcast was brought to you by Cherry Health, the healthcare jobs network with over 35,000 jobs across Canada and the US. Physicians, nurses, pharmacists, and all other healthcare professionals can sign up for free. Start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across North America. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum, with thousands of new jobs posted every week. www.cherry.health to get connected today.
Some of it is still under NDA because it hasn't been fleshed out. And certainly the AMA have been working tirelessly. I will say that. I was surprised at how collaborative the government has been. Certainly being an outsider for so long and just reading the news and getting the lay of the land or the perspective from a media standpoint, I certainly initially was under the impression that there was a breakdown in negotiations, that there was a nice little iron curtain and nobody understood the other person's perspectives. That has not been my experience on the task force. It has been really collaborative. And incredibly professional, despite the high emotions and despite the high stakes. Everyone seems forward thinking and working towards the same goal. You'll often see people stuck between a rock and a hard place where this is the pot of money we have to work with. So how do we make the right choice? How do you do the right thing right when you have these confines? Ideally, every family physician in the province would be granted an extra $100,000, for example, to stabilize their practice, which would give them about 6 months worth of stability in order to give us time for the LFP to kick in. And again, these are just my observations from working in the clinic this past year as a resident physician and seeing some of the business numbers be moved around and highlighted. In terms of proposals, there were different tiers that were proposed. And I will say that our partners at AMA, alongside PARA, made the recommendation that physicians, even with smaller panels, should be eligible for the stabilization funding, because many of those physicians with smaller panels also do work outside of the clinic. They might teach more frequently. They may have a small practice for lactation or maybe low-risk OBS, or pick anything, like oncology would be another example. And those individuals may have smaller panels, but those panels likely are more complex with people and patients with significantly higher needs that take more time to take care of. So their billings will be very, very low if they're fee for service, which makes this funding model that much more important for them. But if they're excluded because their panel size is not quantified either appropriately because their EMR isn't connected to CPAR, or it's not quantified appropriately in CPAR, or they legitimately have a smaller panel because they provide more complex service either elsewhere or within the clinic. Those are the folks that really need help too. So I think that's really where the pushback is, and how to get around that. I certainly don't know the answer, but I know what's fair. And I also know that people are stuck.
What did you think about the process? Because I think that's a big part of why, primary care and the government are at odds with each other so much, is that the family doctors just feel like unheard. What did you think of the actual process in terms of the task force? You said, they seemed like the government and the other individual collaborators were actually like fairly open-minded and willing to talk about a lot of these things, and you were sort of surprised about that. I don't know if you can speak more about the actual how it went down and the logistics, or how it is currently operating.
Yeah. Like I said, it was very collaborative, even from the very get go. There was not a meeting that went by that didn't have a component of the discussion that was incredibly heated. And in some cases, people needed to take a break. So the process was enlightening in that respect. One of the key things that I learned was it's the professional that makes it's the person behind the profession that makes the professional, not the profession. Does that make sense? So you comport yourself as a professional if you are that person, not because you have a specific title. And that's something that was very enlightening during this task force process. In some cases, comments were surprising and made some of us wonder what the motivation is. In some cases, the comments were incredibly altruistic and made you appreciate the selflessness of being a physician. So if I had to summarize the process in one word, it would be enlightening.
How many different people were actually involved in the process? Is this like 5 people? Is this 50 people?
So if I had to, I'd say more like 20 people.
Okay. So
yeah.
Reasonable sampling, I guess. And then are the people on the task force like seeking out stakeholder feedback from other physicians and getting other input? Or how does that actually work for putting systems together for a whole province? How do you get all of that perspective?
Yeah, absolutely. So this is why there was such a frequent cadence of meetings, because the individuals who sat on the task force each represented a section of family medicine and also reported into other working groups and committees in AMA and to AMA executive themselves. So the information from, do you want to call them constituents, from the members of AMA, so all of the physicians in Alberta, those opinions were collected quite formally and then was fed up through the representatives, fed into AMA, and then that was used to create these proposals and provide the feedback to Alberta Health on the task force. The same thing was done through PARA. So whatever the information was that was required for the task force. So would resident physicians be okay with 10 grand, right? That's a question. So I brought that back to PARA. We created a survey. We created in some cases, they were informal surveys. In some cases, we had data already from very formalized surveys. That information was then consolidated through the association, be it PARA or AMA, and then brought back to the task force. So the turnover was really fast, days.
And then in terms of the LFP model, what was sort of the outcome of that, I guess, or what was the recommendation going forwards? How did they think that should actually be put together?
The LFP model, as you probably remember, was created by that first task force, or proposed by the first task force, and it was based on an algorithm or a calculation, and they came out to a number. It's intended to be sort of like an ARP, right? So a guaranteed income for a family physician, and with the opportunity to also bill additional services over and above what would be considered your primary care. And it's meant to be competitive with BC and Saskatchewan, mainly because those are the two provinces that seem to be poaching right now. And the data suggests that they're poaching successfully because of their LFP model. So in terms of outcomes, we know that the government has committed to a model of the same nature. However, they haven't yet committed to what does the algorithm look like and who would qualify. And that's where the pushback was, because the proposal was that anybody practicing family medicine that has a panel size of at least 2 should qualify for this funding model. And the pushback seemed like it was quite arbitrary. So we're in a bit of a standstill now to understand the government's data perspective, where did they come up with their number? And then, of course, AMA is providing some feedback as to where they came up with their number. I don't think either number is anecdotal or frivolous in any way. I think that there is data behind each. It's just presenting it and making sure that that evidence is well understood. So that's where we are at the moment. Of course, there was commitment that payments would start in April. So we hope that in a week, at the end of March, I guess that's not a week, that's less than a week, that there will be like a full formalized announcement of the breakdown. But it's sort of in the minister's hands at the moment.
Throughout the process, I imagine, this was sort of enlightening. What did you discern in terms of what is the actual outcome or the agenda of both sides? You've got the AMA and then you've got the government, and they're in charge of this gigantic healthcare system with a lot of complexity, a lot of like different voices, people advocating for different things. Did it become more apparent of what each side was truly trying to optimize for?
Again, the mandate was to increase the stability of comprehensive care in Alberta. And
what is that? Is that just doctors practicing, exactly. Or what the heck is stability?
I think if you want to break it down into very layman's terms, it's make sure that no more family docs leave the province. Make sure that no more family docs close their practice. Find a new way to attract and retain these new family physicians who are transitioning to practice so that they pick up a primary care panel. I think fundamentally, and in its most simplistic terms, that's what it meant. And then when you translate that to how do we do it, I think it was essentially, we need to throw money at this, but how much money is good enough? And how do we spread it out with the bucket that we have? And that became the point that in some cases there was opinions that perhaps crossed the line of professionalism on both sides. And that was the part for me that I kind of went, ooh, that was the enlightening part for me. And, when you're in that situation, you feel so compelled to advocate for something so important. And that importance is making sure that Albertans have access to primary care. How do you then tease that apart from the income of a family physician? Because they're tied together, right? And teasing that apart is impossible. But how do you advocate without looking at the family physician's income as being like the primary driver? It's difficult to do that. So you can see how the flavor of some of the meetings might have felt kind of icky if you were a layperson just observing it without the context or without the understanding of how we got here. It's been 4 years getting to this point.
Well, it sounds like, it really was boiling down to a recruitment and retention issue. And I guess both sides, the AMA and the government are aligned that they want to recruit and retain as many physicians as possible. So that's a good thing. But then, I guess, how do you actually distill it down to those individual measures, right? When it comes to any job, be it a physician thing or not, obviously the pay and remuneration is top of the list, or often top of the list, but there's things that go into that too.
100%. Like, for example, the administrative burden of family physicians and how many doctors face hours that are completely uncompensated, that it creeps into their personal time. So there's an entire element of that task force focusing on reducing the administrative burden for family physicians. So that was also incredibly helpful because there were solutions that were proposed to reduce filling out forms, for example, or simplifying criteria for certain programs that people so desperately need access to, like Alberta Works or AISH, or even workers' compensation. These forms take forever. Disability form. I filled out a disability form for a long-term care patient the other day. It took me 22 minutes of time. So, these things, reducing the administrative burden gives you time back in your day to see more people. So it directly translates into increasing access for patients. Again, going back to the mandate. But these solutions also aren't turnkey. In some cases, we needed development or expansion of IT infrastructure. And in some cases, you need funding to disseminate that among the clinics, among the practitioners. It's not free. You can't just log in. It's not like Cherry where it's free and you can make a profile and network with all these great people. You actually have to, you have to pay for these systems. So it always boiled down to, where do we find the money to do this? So we can propose solutions. We can reduce the burden in some cases by making forms less cumbersome to fill out, making it so the government accepts forms that are more basic, for example, but you still have to have those solutions in place in order to increase access. So it certainly was more comprehensive than, where do we put the money? There was the administrative burden piece. There was the longitudinal family practice funding model for later on in the road. There was, how do we keep physicians in their practice right now until that LFP model can take place? And then how do we make sure that residents who are graduating now come and fill in the spots in primary care, and either don't leave the province or don't just decide to locum everywhere without taking a panel.
And so let's chat a little bit more about the residents side of things. So, I mean, retaining them obviously is also paramount to the province's, primary care system functioning properly. It's interesting that the 10th bonus, in the resident world was sort of scoffed at. Back in my day, 10 grand was a lot of money. But then again, that was before inflation started eroding away at the purchasing power. And I guess, I already lived in Alberta. Would 10 grand be enough to make me want to move here from Vancouver, or make me want to stay here if I was from Toronto? That's a good question. It doesn't sound like it, though.
No, that was the flavor. The residents that did respond to that survey, 10,000 it didn't meet the threshold. And mainly because it equates to the average of 5 months worth of interest for most of their student loans that they've had to borrow in order to pursue this degree and this training. And so 5 months of interest to stay for 2 years when things don't look that great for the practice. When you see physicians leaving, that just didn't seem like it was stable. So
yeah, no doubt. Okay.
There was a minimum threshold.
Go ahead.
There was a minimum threshold where people said, yeah, I'd consider staying. And it was $50,000. They were like, okay, that would cover, my interest for the next, say, a year and a half, 2 years. And it would also give me the money I need to write my exams and pay for my mandatory courses out of pocket that are in addition to residency that we must fulfill. So it was enough to cover those costs, but 10 grand wasn't. So when they surmised essentially how much they needed in order to cover just those basic things, like your exams, your ATLS and ACLS and BLS and PALS and NRP and alarm and all the things, that equates to, in some cases, 10% of your gross salary per year for those courses. So yeah, 10 grand didn't cut it. Seemed like 50 grand was the minimum. And then the other issue was that residents didn't want to be forced to go to a place where they had no connections. They didn't have any network. They didn't have colleagues or friends or family. And so there is, I think, the appeal from the government side is to connect this stabilization funding for the residents to a specific geography, which is a lot like what the Reside program was. And you might have some uptake from some individuals, and they may go there for the 2 to 3 year time period. But we also know from historical data that those individuals who weren't from that town or didn't find a way to inject themselves into the community didn't stay after their mandatory time was complete. So how do we make then this stabilization and recruitment funding for residents who are going into practice? How do we get it so that they are practicing in these areas, but they're not forced? And how do we make sure that the funding that we provide to them is sufficient to compete with the other provinces? Because we're not in isolation. We're not in a bubble. So if BC is wheeling up with a wheelbarrow full of money saying, here, we'll pay off most of your debt, and we don't care where you go, just set up a panel. I mean, that's a way more attractive offer for somebody who isn't attached with a family.
What is the main concern from residents? Like, what is their primary issue? Is it the funding and just the compensation?
Right now, the main concern is the resident salaries being so low. So we are about 12% below the median across Canada. And so when people are considering matching to a province after CARMS, one of the things they do look at is how much they will be paid, because you can imagine that between $50,000 and $60,000 actually falls below the minimum wage line. It falls below the poverty line, especially in Calgary. So if you have to consume more of your debt or consume more of your credit and contribute to your debt in order to fund your residency, when you're a physician, you're making decisions, and yes, you are still a learner, but you're sort of in that gray area of making very important therapeutic decisions. You're the one that's on call at night. You're the one that's taking care of the critically ill patient at 3:30, 4 o'clock in the morning, and your nursing colleagues are coming to you for orders and direction and so on. And your counterpart, if you want to compare across professions, say, for example, like a fourth year nursing student, they are still under the tutelage of their preceptor, but they're being paid a salary, and their salary actually is more than a resident salary. And yet, like, they're not holding any bag, right? The resident physician is holding a big bag of responsibility. So if you want to compare provinces and professions and levels of training and so on, that is really the biggest concern of residents right now. We appreciate the fact that our current agreement, the stakeholders that are named, are both PGMEs, which is the postgraduate medical education groups for the University of Alberta, University of Calgary, which of course are the medical schools in the province, and then para. So we negotiate with the two PGMEs and then Alberta Health Services. We, at the moment, don't have any negotiation power or privilege with Alberta Health. And it's Alberta Health that has the funding to make it better. So therein lies part of the issue, is we actually need a higher salary in order to sustain our education and our training until we're finished so that we can practice. But the second thing is that we need to be able to negotiate with the people who make those decisions as opposed to going through the other parties. So having them named as a stakeholder in our agreement would be a huge benefit to the resident physicians, for sure. And I feel like we're getting there simply from the simple fact that we were actually afforded the privilege to sit on the task force and now on the Provincial Primary Care Network Committee. So our voice is now being invited at all of these different tables. And so I think that there's more awareness as to the importance of human resource planning from the physician standpoint, and that really comes from entertaining what residents need.
I'm surprised that it's set up that way, where the actual decision maker is not at the negotiating table. That sounds less like a negotiation and more just like some people hanging out.
That you're not wrong. And this is probably why the last two negotiations went to arbitration. Because the people who had the power to make the difference weren't at the table. And the individuals who are at the table are bringing back the message to Alberta Health, but are they really going to advocate strongly if really they're not the ones who are impacted? So can you trust that the information was translated appropriately? Was there the appropriate intonation or intonation in the voice to impress upon the importance? How can you know that, right? I think actually 9 years ago, Alberta Health was named as one of the stakeholders in the para agreement. But when Alberta Health Services took over the operations of everything, then Alberta Health actually stepped off as a stakeholder and AHS remained as the sole stakeholder. And as you are aware, AHS for the longest time, and I think up until recently, didn't have a human resource planning strategy when it came to physicians specifically, because the impression was that physicians are contractors. And so they weren't part of the AHS structure, which was a huge miss. So I think we're trending in the right direction. I think the trajectory is that resident physicians are now being heard and understood. We have a ways to go yet, but I do feel cautiously optimistic.
Did you have a chance to look at any of the recent CARMS match numbers that just came out from the first round? What did you think there?
Yeah, so this is a great news story, actually. I was a bit surprised. So you probably remember historically there's been sometimes 20, 22 seats in family medicine that went unmatched after the first iteration, or 40 in some cases, and then another 15 or 10 after the second iteration. And it was like abysmal, right? So we were thinking, how are we going to attract more people into family medicine? Part of sitting on the stabilizing comprehensive primary care task force was so that we had an in with the information and we were able to bring some information back to potential family medicine resident candidates, so medical students who are looking to be family doctors. We were able to take some of that information and actually share it. So it became part of a marketing strategy. So this year, in the first time of the history of the school, we have 100% of medical students who have matched in the first iteration, and we have our urban family medicine resident spots filled in the first iteration. So this is unprecedented for our program, really great news. And I would say that part of that success is attributable to the fact that we were able to say, look, we're actually speaking at tables where the government is present, we're being heard. And yes, our negotiations are coming up April, May, June. But right now we're being heard and understood as to what the most pertinent issues are. And look, they've provided us $8 million worth of funding. We don't know what that looks like yet, but at least they've committed this money to us. So we were able to bring that back to these medical students who are like, I'd really like to do family, but should I go to Nova Scotia? Because these places have an LFP that are in place, and they, the resident salaries are so much higher, and they also support us with our extra curricula stuff that we need to have in place to graduate to R2 and then to transition to practice. So huge win. Carm's match was a big surprise, but also a great celebration this year for sure.
So the people have voted. It sounds like things are looking up here in Alberta for the urban centers for sure. Do you have any thoughts? I heard that they included IMGs now in that first rank match. Like, does that confound, in terms of variables for that equation? Can we say that, okay, definitely Alberta, Calgary, Edmonton, urban programs for family practice are becoming more desirable? Or do you think there's a chance, I don't know if there is any actual numbers that you can see of like how many of those IMGs that usually come in the second round? Can you speak to that at all? Is it definitely a positive sign?
I still say it's a positive sign, but you're right. So in the first iteration, this is the first time that IMGs are included in the first iteration. And 15 of the spots went to international medical graduates, which is still a huge win because these individuals are highly trained, highly skilled, highly educated. And to have them as part of our program alleviates the strain on the system as well. So yes, it does confound the data ever so slightly. But if you look at it apples to apples and you remove the IMGs, there were still more first round pick matches from Alberta trained residents or medical students, Canada trained medical students, I guess.
What do you think about the IMGs being in the first round? I haven't really thought about this at all. I think it makes sense. Is there anything that would be a detriment to that? For our Canadian trained medical graduates, then I guess the second round is probably going to be quite a bit more difficult. Is there any more to that?
So there won't be a second round. So that's part of it. And you know what? If I'm being honest, I didn't reflect on how having the IMGs included in the first iteration would necessarily impact Canadian trained medical students. Certainly, I think in areas
They've gotten rid of round 2 though.
Yeah. So because we matched 100% in the first iteration, there will be no second iteration.
Okay, but for the schools that didn't fill up 100%, there still is a second round.
There is, yes.
Okay, gotcha. Sorry, I thought they completely changed it around there. That makes sense though.
Yeah. So there's still two spots in Medicine Hat that are unfilled, and one in Grand Prairie.
The shout out to Medicine Hat if anybody hasn't matched. So backing up then, what is a PGY1? So you've done your undergrad degree, you've done your medical school, and now you are a paid functioning team member in the hospital, in the clinic. What is the provincial salary for that first year resident currently now in Alberta?
It's about 58,000.
Okay, that sounds pretty similar to what it was like 6-7 years ago when I was doing
It
my
has not
training.
changed.
So okay, nothing's really changed there.
Yeah.
And what does that work out to be per hour, you think, when you include all the 26-hour shifts and overnights and things you do?
Yeah. So when Para actually did the calculation out and took the average number of hours worked per resident over all of the residency programs, the average number of hours worked per resident per week is 80. That's the average. And so you're paid, maybe I can say this, minimum wage. So if you had a barista that was making minimum wage, that barista is making more than you when you're on call. So depending on the number of hours that you work, you could be making only $8 an hour. There was one week that I made $4 an hour.
Congratulations. Don't spend
Yeah.
it all in one place.
Well, it was like back in 1997 working as a housekeeper, $2 an hour, and I thought that was great.
But what is it like in BC then, or versus Saskatchewan? How does the two compare apples to apples versus working in Alberta as a resident?
Yeah, so those starting salaries are more like 72, 74.
Okay.
Yeah, and then some provinces are 68 maybe. So about $10,000 gap or 12%. The median is 12%. So Alberta is about 12% lower than the median. And BC and Ontario are some of the highest. Alberta typically usually tries to compete with BC and Ontario because just the status of the province, right? So should we be successful in the negotiations, our hope is that we would be competitive with those provinces again. Those are also the provinces that usually take away our medical students and attract them to train as residents in their provinces. So keeping our students that have trained here in provinces it's a priority, right? Because you have individuals who are well networked, they understand the system. I've worked all over Canada, right, in clinical environments. And I can honestly say that Alberta is one of the, if not the top system to work in as a clinician. As much as we complain about it, the infrastructure that we have available to us in order to care for our patients well and exceeds what is available in Ontario and BC. So it's important to have the medical students who've trained here stay here because they understand it. But it's also really important to have residents who are trained in the other provinces visit here so they can see essentially how great it is. Despite all of the other noise, the system that we have in terms of communication with each other, in terms of the patient information that's accessible when you're practicing, that exceeds anything that I've practiced in any other province.
Well, and so the province runs fairly smoothly from that clinical perspective. It's definitely challenging from a fiscal perspective, though, when the residents are making that, right? The med students are making that decision, $12,000, $13,000, $15,000 when you're considering your salary from one province to the other definitely goes a long way. You mentioned earlier, Calgary has become one of the highest cost of living places. How does that work? I used to think Calgary was sort of this little oasis desert, and this was the one spot that's still affordable.
Yeah, I think part of that is that there isn't rent control, right? So people's rent can be increased month over month, year over year, without any checks and balances. So that's part of it. Property taxes have increased. The cost of gas and energy has increased. Insurance costs. So essentially just the cost of living in general. But if you look at residents or medical students, most of them rent. Most of them don't own their own home. And even if they did own their own home, then we have interest rates that are higher than they used to be as well. So the cost overall of housing in general has skyrocketed, 20, 30%, even just from 5 years ago. So that's a huge deal. And then you look at food prices, and food prices affects everybody. It's unfortunate, but we do have some resident physician colleagues in the province that do need to use the food bank. There were several that were actually unhoused this past year.
Wow.
So can you imagine being a doctor and you are homeless? Can you imagine that?
That's rough.
Mean, it is.
No, that is wild.
And I think that the public perception is you're a physician, you make millions, and that is not, certainly as a resident, you don't even make ends meet at this point. And then seeing what I see in community family practice, these physicians are working so hard to make what I made as a pharmacist, essentially.
That is crazy.
It is crazy.
But what else is Para have on the go? Congrats on the recent appointment, or sorry, election, now as the president-elect for the association for the residents here in Alberta. I see you finished medical school, like 9 months ago, and you're now the chief resident, president for the provincial association, consulting for the AMA and the government on task forces. Your political career here in medicine seems to definitely be taking off. What do you got planned for the province for the Residents Association coming up?
Well, so I shared that we're going into negotiations. First of all, thank you. I appreciate it very much. So Para is going into negotiations April,
impressive
May,
few
June.
months.
Yes, it's been busy. It's been very fulfilling. Honestly, I feel most fulfilled when I'm advocating for important things. So within my wheelhouse, and certainly something I'll continue even well into my clinical career. So what we have on the go from Para's perspective, we'll enter in negotiations with both PGMEs and AHS this coming spring. So April, May, June. And after that, of course, any changes that are made to our agreement will then need to be implemented. We spoke briefly, maybe a little bit more than briefly, on how important it was that resident physician salaries were looked at. The other priorities are actually our duty hours. There's a duty hours working group that we're looking at what is fair on call, what is considered a weekend. Is it humane for somebody to work 26 to 30 hours without any sleep and without any breaks and not be compensated for it? Looking at those kind of dynamics within our training program. There's a historic element to residents going 26-hour shifts without sleep. If you look back at what the origin of that historic relevance is and where it started, I think, in Massachusetts, or at least in New England somewhere in the 1800s, with a physician, a surgeon, who apparently didn't sleep, so he expected his residents not to sleep. And he created the first formalized residency program in North America. So that became part of the structure. It was found out after he passed away that he was actually on cocaine all the time and using stimulants to stay awake. So this really
the founding father for our medical education system?
So you have people, you have resident physicians who are making really critical decisions on their 24th, 25th, 26th hour without rest. And then they get ready to go home, and the thinking is, you're not safe to drive because you've been awake too long. You're legally drunk, so we'll pay for a taxi for you to go home. And I'm sure you can appreciate how paradoxical that is, that I would be dosing digoxin or phenobarbital, really heavy-hitting medications. I would be dosing that half an hour before I was not allowed to drive home. So these kinds of ideas around duty hours, what is appropriate, acceptable, and what is compensated fairly, that's another component of what we hope to discuss with the PGMEs and how we can find solutions to improve resident wellness. The burnout rate is actually higher now than it was 5 years ago. And it mirrors that or even exceeds that of most practitioners, unfortunately. And part of that is the call shifts, et cetera, but it's also the amount of clinical information that we're taught. So it went from being something like 400 conditions that you learn about to now it's 2,080. Anyways, the exponential jump in the last 10 years has been so significant. The evolution of clinical technology that we need to be able to use in the practice, like point of care ultrasound at the bedside. That's just one example. There's a multitude of different injection procedures that didn't exist even 10 years ago that we should be competent in. So there's the learning itself has accelerated. And this is part, I think, of why there was a push to create the family medicine program as a 3-year program as opposed to 2. And then there was pushback. I'm a pushback. I think 2 years is good. We just need to be efficient with the teaching and the learning. So that's another priority, duty working hours. And then the third priority, and probably one of the most important, would be to continue to engage with Alberta Health and with our government officials as resident physicians of Alberta, so they understand that we're the pipeline to creating doctors in this province and providing access to patient care. You can't farm this out. You can't sprinkle privilege on other adjunct healthcare providers and expect that that is going to then elevate access. It doesn't really work like that. So that will be another huge priority, maintaining those great relationships and that conversation and the collaboration that we've enjoyed so far.
I mean, in terms of that, the residents are that future of the province's healthcare. It's very surprising to hear that they're just like getting neglected to that degree, like financially and otherwise, right? Like when we're talking with clinics, when we're dealing with all these different physicians across the province as part of Cherry, the question's always coming up of like, how do we recruit doctors more successfully? And like one of the biggest things that people are often like lacking on is just having learners come through, the residents, having the actual students come through as a teaching unit. And so when you apply that same philosophy of, okay, well, having learners come through to this individual practice, on a micro level as being one of the best recruitment and retention strategies, it's absolutely absurd that like as a province, we're entirely neglecting that entire avenue to get doctors to come here and do their training. Like that's who's gonna stick here in the long run, and that boggles my mind. And then in terms of the duty hours, just to kind of throw in a little analogy, I remember coming home from one of those 26-hour call shifts one night, and I stopped at the mailbox to get my mail, and I like got out of my car, and I had to go through, I couldn't remember which mailbox was mine after like driving back at the community one on the side of the street, and I went through all of the mailboxes twice before I found the one that was like, if any of the neighbors saw me drive up and then get out and try all the keys on the mailbox twice before being able to find it, they would have called the cops for sure, thinking I was drunk. And that's like how we're in the hospital and just making decisions overnight. It's crazy. It's interesting that the guy who came up with this was just snorting cocaine all the time.
All the
makes a lot
time.
of sense now. My goodness.
It is an archaic way to learn. And certainly the way residents were, their structured training was designed came well before our understanding of consolidating information during sleep and how important sleep is for learning. So it's an archaic practice. We know this. It also takes about 20 years to institute change for historical things or from historical things. So we've got a ways to go, but I am optimistic with at least the ears that are now listening to us. So that is positive. And if you also think about it, it's the resident physicians who are in the hospital taking care of the patients most of the time. And this is something I don't think that the public is aware of necessarily. So you go to the hospital, whether it be emerge or, at an outpatient clinic in the hospital, or say you're admitted, the physician that's seeing you is a resident physician. And you might see the staff, but that staff is going to see you for 2 to 5 minutes. And they have learned about you as a patient from your resident team. So it's the resident physicians that are propping up this system. And if you don't have resident physicians in the hospitals working, you don't have a hospital. You don't have a healthcare team, because those are the individuals who are there. So I don't know that that's necessarily well understood from a public perspective. Certainly, even as a pharmacist, I didn't quite understand that. Even working as a hospital pharmacist, sure, I saw residents rounding and stuff, but I didn't understand their level of responsibility. It wasn't until I started practicing medicine myself that I had that appreciation.
The learners really are the backbone. So hopefully, again, seems like the initial data here from CARMS this year is looking positive. Fingers crossed that trend continues. What are you looking forward to the most for this upcoming year then?
Oof, that's a tough question. I suppose I'm most looking forward to hopefully amalgamating healthcare teams into more comprehensive based care. So I think the old school way was patients would present to a medical clinic, they'd see the medical office assistant or perhaps a nurse and then see the doctor and then go home. And what I've been exposed to this year are medical care teams that have other adjunct professionals on the team. So nursing and occupational health and mental health, for example, diabetes education, pharmacists. And those patients have a greater circle of care around them with more points. And they are also the individuals who are hospitalized less frequently. So we have this data to demonstrate that. And I think really my hope is that we'll be able to spring up more of those types of practices in the province with this new funding model and with the greater understanding that it benefits patient care.
It will be cool to see how this all shakes down. Definitely looking forward to, hopefully we'll have the announcements come out any day now. Maybe then we can talk a little bit more candidly about the actual outcomes and perhaps your thoughts there and how things actually turned into practice. We'll have to have you back some other time. We're running out of time here. I don't want to take up too much of your afternoon. One final question we ask everybody on the podcast at the end. What's your personal wellness tip? How do you actually keep yourself functioning? What's the number one thing?
So I'm pretty busy with 3 kids, 1 in hockey and 2 that play other sports. So a lot of my energy is devoted to kid stuff outside of learning and outside of my other roles. But the one thing that I try to make sure that I always have time for is exercise for myself. Something is better than nothing, even if it's only 5 minutes, even if it's only 10 minutes, I make sure that I have time for that or make time for that. If I can spend 20 minutes washing my face, I can spend 10 minutes doing some crunches and some push-ups. So exercise is paramount, fresh air is paramount. And then one thing that I have on the go consistently is a revolving chronological list. And on the top of the list are the dates of important things coming up throughout the year. And then on the bottom of the list is this week and what it is that I need to get done in order to accomplish the goals at the top. I pick 6 things a day, no more than 6. And I make sure that I scratch them off the list every single day. And I usually make a new list or add to the list at the end of each evening. This keeps me on track and it makes sure that I'm not super anxious to try to get everything done. One of the questions that I often ask is how can you be lead resident and parapresident and a mom of 3 and a resident physician and your senior advisor of pharmacy services and you're going to exercise and still try to do tri? Like, how do you fit all of that in? You have to be focused and efficient. So the lists keep me focused and efficient.
6 things a day. Okay. So organization, discipline, and then physical fitness all comes together to be a high functioning doctor pharmacist. Love it. Thank you, Dr. Pauwlina Cyca, for joining us today. Really appreciate it.
Thank you, Jordan. It was nice to be here.
Thank you for joining us this week on Leaders in Healthcare. If you enjoyed this episode, please like, subscribe, or leave a comment. And if you found this episode helpful, don't forget to share it with your network.